Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and welcome to the first Journal Club of 2025. Certainly, it is an honor to start the year with such an impacting speaker and also addressing a very important paper. I want to also thank ESGO and IGCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. So participants with a camera turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentations. And if you're having any difficulties or questions, please send a message in chat and our technical support team will assist you. Definitely, we will have lots of time for questions, and we encourage you to submit your questions via the chat function throughout the course of the Journal Club. So as I said, again, thank you for joining us. We're really very, very excited. This month's lead article is titled Minimally Invasive Compared to Open Surgery in Patients with Low-Risk Cervical Cancer Following Simple Hysterectomy, an exploratory analysis from the GCIG CCTG SHAPE trial by Professor Marie Plante. We're really very, very honored that you have joined us, Marie. Thank you so much for accepting our invitation. Of course, obviously, thank you for sending the manuscript to our journal. And I know that you will share some of your insights into the article, and then we will proceed with a number of questions from our fellows. And then also we anticipate lots of questions from our audience as well. So I'm going to hand it over to you for a summary of the article.
Hi, so thanks, Pedro, first for accepting this manuscript publication and making it a lead article. So it's quite an honor. And it's also a pleasure, actually, to do this fellow discussion. This is my first experience as such. I kind of look forward to it. So I will briefly summarize in a couple of slides the main results of the manuscript, and then we'll go on to having the questions. So as you can see, based on the title, it is an exploratory analysis. So that means that is some of the data that we've extracted from the main manuscript to look over specifically at the simple hysterectomy group of patients within the SHAPE trial. All right. So why did we do that? Well, as you know, the original LAC trial publication demonstrated that MIS radical hysterectomy was associated with worse disease-free survival and overall survival among patients with early-stage cervical cancer. But that, as you probably can recall, included patients with lesions all the way up to 4 centimeters. So what wasn't clear is whether this conclusion applied also to patients with smaller disease, under 2 centimeters, with low-risk disease following simple hysterectomy. So we, as I said, extracted from the main SHAPE trial, we extracted all the patients who were randomized to the simple hysterectomy arm, and we conducted some Cox model analysis for univariate and multivariate analysis. And we wanted to assess the association between MIS and open with the clinical outcomes. And the clinical outcomes that we looked at were pelvic and extrapelvic recurrence-free survival, recurrence-free survival, and overall survival. And we also looked at a number of variables like race, age, performance status, BMI, the usual things, stage, histology, grade, diagnostic procedure, LVSI, and so on and so forth. I think you can read them as well on the slide. So those are the elements and variables that we looked into as well. So in a nutshell, that might be the main slide. We identified 338 patients who had the simple HIS. As you can see already from looking at the top here, surgical approach was not randomized, right? So it turns out that 83% of patients who had the simple HIS had the procedure by MIS, and only 17% of simple hysterectomy were done by open surgery. So that already shows that there's a discrepancy or between the choice of surgical approach. which was left at the discretion of the surgeons. And we'll get into that with the question. So with a median follow-up of 4.5 years, this is what we see. Well, so most of the variables were equivalent or similar between both groups, even though it wasn't randomized. But there were 2 or 3 things that are worth mentioning. The proportion of patients who had residual disease in the hysterectomy specimen ends up being that there were more of those cases in the open surgery group as opposed to MIS. And that was probably the only characteristic or variable which was statistically different between the 2 groups. However, in terms of recurrences, even though it looks more in the MIS because it's 12 versus 3, in proportion of the denominator, the percentages are similar. It's not statistically significant. What is concerning, and we'll get to that as well in the discussion, is when we look at the different kinds or types of recurrences. There were 2 in the MIS group, which were in the form of carcinomatosis. So that's 16% of the recurrences were in the form of carcinomatosis. And there were none in the open surgery group. So we saw no statistical difference between MIS and open surgery in terms of the outcomes. Again, I remember pelvic, extrapelvic, recurrence-free and overall survival, we saw no difference. But since surgical approach was not a randomization factor, we think that our data need to be confirmed or evaluated in larger prospective trial to confirm our results, essentially. I believe that that's the last slide. Yeah. And that's
well, Maria, thank you.
Yeah.
Yes. Thank you very much for such an excellent review. And I do have to say, incredibly well-attended journal club. We have 72 attendees so far. So I know that there's going to be a lot of questions from the audience. And certainly, obviously, we have questions from our fellows as well. So I think, you know, it's important to highlight, and I'd love to hear your thoughts with regards to how data is interpreted. Of course, obviously, this is a paper that is derived from the SHAPE trial. This is Marie Plante presenting this information. Should we take this paper and say, all right, as I see it, this means that MIS is okay to proceed with a simple hysterectomy, and that should be my standard moving forward?
Well, I guess that's the key question. I think that, as we say often, the devil is in the details, right? And I think that the key point is patient selection. And if you truly identify patients with low-risk disease, clearly meeting the SHAPE criteria, and particularly in patients who've had a pre-hysterectomy LEEP or cone as their diagnostic procedure. And if that LEEP cone had negative margins, I think that the probability of recurrence in those ultra low risk patients, I think is very low. In which case, I would tend to think that a simple hysterectomy, and I would go as far to say as with MIS, is probably safe. But again, that is exactly what the LASH trial is going to be designed to show. And we might talk about it a little bit later. So I think that we ought to remain cautious and critical about our results. Our analysis has got weaknesses. It's got, I would say weaknesses in the sense, again, that surgical approach was not randomized. So there are biases there to begin with. You've seen that there's quite a bit of a difference between the proportion of MIS and open. There were 5 times more MIS than open procedures for the simple hysterectomy patients. And then the last thing I might say is that the number of recurrences is quite low. There's only 12 of them. So I mean that there's a point where there's so much you can tell and extract the data with 12 recurrences. So an event that doesn't occur frequently might not be seen in a group of 50 patients, but it might be seen in the open group or the MIS group that has 5 times more patients. So that's why, I mean, it's hypothesis generating. And I think that it needs to be confirmed in larger groups patients, essentially. I don't know if that
Perfect. No, I think that's
sense to you.
great. That's a great point and a great answer for starting this discussion. And we do have the principal investigator for the last trial joining us as well. So we're going to tie that back into that question at the end as well. So Nico, thank you for joining us in this journal club.
Thank you.
So with that, then we're going to go to the first question by our newest and most recent group of fellows. Welcome to the 2025 fellowship. And from the University Hospital of Heidelberg, Kira Fisher.
Yes, thank you for the opportunity, Marie and Pedro. My question is how you interpret the findings in comparison to the subgroup analysis of the LAC trial, where they also checked for patients with a tumor size of less than 2 centimeters and showed that they do profit from open surgery.
Aha. I love the question because I scratched myself over this when writing the manuscript. So in our publication, we show no difference in outcome between open and MIS for patients with a simple HIS. That's what we show. Okay. Our data indicates a 3-year disease-free survival of 96.5% for the patients who had simple HIS by MIS. 96.5. Whereas in the updated LAC trial publication that Pedro published in May of 2024, he shows worse outcome for patients who had a rad HIST by MIS with a recurrence-free survival of 92%. So that's intriguing that in both cases, we're dealing with patients apparently with lesions under 2 centimeters, and rad HIST MIS does worse than simple HIST MIS. That's unusual, right? So I thought about that, and I guess the main explanation that I could think of is that in the SHAPE trial, we did not only select lesions under 2 centimeters, but we selected low-risk patients with limited depths of stromal invasion, MRI, and kind of well-selected small groups of patients with low risk. Whereas in the LAC trial, it might have been that they included patients with lesions under 2 centimeters, but perhaps with more deeply invasive lesions. That's possibly an explanation. The other thing is that we don't know exactly the proportion of patients who had prehysterectomy LEEP cone and who had negative margins and no residual disease in the hysterectomy specimen. So for instance, again, there might have been more patients in the LAC trial who had macroscopic or residual disease in hysterectomy specimen at the time of the hysterectomy, which maybe have explained a higher risk of recurrence in their MIS group. So obviously those are, I would say, inherent limitations when you conduct post-hoc analysis and reanalyzing data from studies that were not designed to evaluate a particular endpoint or outcome, then you lose some of that information. So I don't know exactly for sure. Those are hypotheses. I don't know, Pedro, if you have any other ideas to explain the differences between, our results.
Yeah, no, that's actually, you articulated it very, very well. And that's exactly the point to be taken from this, is that both analyses of that patient population are post hoc analyses. So again, it's just observations. This has no really scientific weight when you look at post hoc analyses. And then also when you're looking at numbers already in a setting of patients where there's, as Marie mentioned, there's so few events, then you say, well, look, in one, it was 96%, and in the other one, it was 93%. When you're looking at percentage differences, you add one patient with an event in any one of those groups, or subtract a patient with an event in any one of those groups, and then you already have either a similar percentage or a broader percentage delta. But again, it's emphasizing that neither study was designed to look at that question. And again, the differences in percentages should not be really taken as having any major scientific weight in terms of establishing a practice. But also, I mean, to Marie's point, which she of course obviously outlined perfectly well, is that you get a patient there that has more than 10 millimeters invasion. You have a patient that has a positive margin on a cone. That's already two different patient populations. So you cannot just say, well, look, one is 96, the other one's 93, so therefore 96 is better than 93. And what happened there? So I think it's just, again, observations.
Exactly. Yep.
All right. So are there any questions from the audience? Anyone that has anything to add about this particular point and this particular question that Kira raised? Otherwise, yeah, was there a question? Please put your questions in the chat if you have a question. But I see Nico raising his hand. So Nico, please proceed. Go ahead.
No, I don't want first of all, thank you, because this is amazing meeting, and congratulations to Marie for the paper, which I know very well because I had the chance to read earlier. So congrats. Very quick question, so I don't steal the time of the fellows. The first is those two patients who had carcinomatosis, did you manage to go back and check whether they had any uterine manipulator? I assume they didn't have any conization earlier before the hysterectomy, but I was wondering whether it was known about manipulation.
Right. Unfortunately, we have no information on uterine manipulator or protective maneuvers that we now talk about so much. I wish we knew when we designed a trial in 2010, so that's a long time ago, I wish we knew then that it would have been such a big deal, because we would have included it in the data form. So the sheets that we collected from all the centers does not include that information, and we just have no way of going back and finding out if that was the case or not. Now, you can certainly assume that those two cases of carcinomatosis were in patients who had residual disease on the hysterectomy specimen, and
Right.
probably contributed to that event. And right, yeah.
Yeah. And I would only add to that, because I know that often comes up, and many will say, well, this is really a poor study. That how could they not give us information about manipulators? And again, to everyone in the audience, and particularly the young trainees, when a study is designed prospectively, oftentimes there is criticism for not providing information that is of interest to you 7 years or 8 years after the study was designed. So then therefore, obviously, it's not really a true valid criticism of the study, because that just was not a factor that was considered integral in the process of that question. So then therefore, it's information that if the investigators were not asked to add that information, you don't have that information. And then, of course, obviously, you can go back and start looking through all of the operative reports, but many times that information may not be there. So, so we have some questions from the audience, and then first one is Costanza Saponaro. Would you consider cervical biopsy ssufficient for patient selection?
Right. Well, okay. So we're I should perhaps just go back just a second, and I want to say this. We've written another manuscript which is under it's completed and submitted for publication, where we look specifically at the recurrences and who are those patients who recurred, and obviously it does sort of suggest that presence of residual disease in the hysterectomy specimen and MIS is not a good combination. And conversely, the probability of a recurrence with a prehysterectomy lead cone and negative margins, that's where the data is best. So I think that sort of suggested that that's the case. So in response to this precise question, obviously, if you see a patient with a visible lesion on the cervix, you take a biopsy, you have the diagnosis of cervical cancer, then in SHAPE, many patients directly went to hysterectomy. And so that probably explains why in some of the analysis we've done, the presence of residual disease does appear to be associated with worse outcome, as opposed to a patient who would have had a LEEP cone, again, with a negative margins prior to hysterectomy, might be protectives. And I don't know, Pedro and I have had this discussion a number of times, and we sort of discussed whether the way to go or the way to the future is to propose for patients to have a LEEP cone aiming with negative margins, to triage the patients to have the proper surgery and the proper surgical approach. What I'm trying to say is this. If the lesion is entirely removed with your LEEP and generally with a cone with negative margins, your pathologist can provide you with an accurate size of the lesion. So you know exactly it's under 2 centimeters, and then you'll know the depth of invasion for sure. And then you can determine ahead of time whether patient truly meets the shape low risk criteria. And then you can decide whether you want to do a simple hyst or a rad hyst. If the patient does not meet the shape criteria, should have a rad hyst. And then you can decide if you wanted to do it with the a laparoscopic approach, MIS, or open surgery. And that is a concept that is interesting to think about. And that's exactly the scheme of the LASH trial, where Nicolo is the principal investigator. It's a prospective simple arm study, exactly as I said, lesions under 2 centimeters, shape criteria, negative cone margins, and then almost 1,000 patients are included prospectively in this study. And so I congratulate Nicolo for putting together this trial. There's been a lot of back and forth discussion, but I think it will provide us with a large number of patients and will provide us with better data than this, as I say, exploratory analysis or ad hoc post-hoc analysis that we're presenting. But so those sorts of things that are hypothesis generating and lead further into other trials to confirm. So, yeah.
Very well. So now we'll go to Thomas Bartel in Vienna.
Yeah, thank you. I have more like a statistical question, namely, as you mentioned, you tried to account for this issue of the lack of randomization, and as far as understood, you decided for the approach of an inverse probability weighting. And I wondered why this approach, not like more conventional one, like a matching approach, or like, for example, propensity score matching.
Yeah, so we have conducted a number of different scenarios and statistical analysis, but and we looked actually at the propensity score matching, and the problem of it is we ended up with a sample size which was in fact a lot lower and much smaller. So for instance, for those who are less familiar, for instance, if we had decided to do the propensity score matching, we would say, for instance, take 2 patients with MIS for 1 patient with open surgery, and we would have tried to match as best as possible the 2 cohorts of patients, but some patients you can't really match and so on and so forth. So we ended up, if we did that, with 171 patients. So then you get the numbers to be lower and with less power. So then that is why we decided to stay with the inverse probability weighting, which gave us the opportunity to evaluate the 338 patients essentially. Yeah.
Excellent. And we'll move to Kira. Elise Yates is in the operating room, so we'll ask Kira to ask her question.
Yes. So as you said before, out of the 338 patients that underwent the simple hysterectomy, 83% had minimal invasive surgery and only 17% had open surgery. And Elise asks, given the surgical approach was not a randomization factor and was left to the discretion of the surgeon, what factors do you think influence the decision of MIS versus open surgery?
Yeah, well, it's hard to say. I suspect that, for instance, like we just said, if the surgeons did a biopsy only and it was a visible lesion on the cervix, I suspect perhaps the surgeon in those cases decided for open surgery. In the main New England Journal manuscript, what we've noticed is that patients who were randomized to have a radical hysterectomy were statistically more likely to have open surgery, whereas patients who were randomized to simple hysterectomy were statistically more likely to have MIS. suggesting that surgeons were visibly more comfortable doing MIS for a simple hyst. And that obviously it introduces a bias. In addition, then there's the surgeon's preference and skills, and maybe some patient-related factors, such as the weight of the patient, prior C-sections, whatever, such that surgeons favored one procedure over the other. But other than that, we didn't ask the surgeons to explain or say why they chose open versus MIS, so I can just have assumptions.
Marie, a question from the audience asked, do you have any considerations regarding a difference in application of the SHAPE trial results for low and middle income countries?
No, not really. And that's a problem of the fact that this is an international study which was run through the GCIG, which is the Gynecologic Cancer Intergroup, and that the vast majority of the countries that participated in the studies are from Canada, obviously, and mostly European countries. We had a few centers from Korea, South Korea, two from Russia, I think, and two from China. But again, this is always what we say is that, you know, those trials, we tried to have it open in Brazil and in a number of low middle income countries, but we run into all sorts of difficulties, which would be too long to explain here, but it would have been better and nicer to have a broader regional representation across the world. But no, it wasn't quite the case with SHAPE.
Excellent. So now we'll go to Switzerland. Christian Braun.
Thank you for the very clear and insightful presentation of the study. I have the same question like Nico. If you have any data of the frequency of uterine manipulators, and you have already explained it very precisely. And I think we're all looking forward to have a clarification in the last trial. So thank you very much for conducting this study. Yeah.
Thank you. But I might want to say.
Nico ran into your question.
Right. Wait, okay, let's go on. Right, move on.
All right, so we'll go on to University of Padua. Matteo Marchetti.
So thank you so much for this opportunity. Part of the answer has already been provided by Marie, but my question is, in the multivariate analysis for oncological outcomes, the diagnostic procedure emerged as an independent predictor for pelvic recurrence-free survival. So why do you think biopsy is significantly less effective compared to conization or lip excision in this context? And do you believe this principle could also be applied to larger tumors, such as 1B2 cervical cancer?
Well, as I think we sort of more or less talked about that a few minutes ago, but, you know, I suspect that my hypothesis is that patients who had a cervical biopsy as a diagnostic modality and who had visible macroscopic lesion at the time of surgery were perhaps more likely to develop a recurrence following MIS, whereas patients who had a leap cone with negative margins or with no or visible lesions on the cervix were perhaps more likely to have MI surgery. So, as I said, we have looked at our data of patients who had a prehyst leap cone with negative margins. We have 174 patients of those. And the recurrence rate is about 1%. So the probability of recurring when you see no lesions or there's no evidence of so when MRI is normal and everything is actually quite low. But when there is visible lesion and MIS, and then that's probably concerning. And those are the cases that we need to be very, very careful. And probably I wouldn't recommend unless you use very strict preventive measures, protective measures. With regards to 1B2, I think it's a long shot to extrapolate that data to 1B2 patients. I don't think that we can go this far. Yeah.
Yeah, and I will just add that it's a question that is being explored. I have noted a number of papers that are looking now at simple versus radical in a 1B2 setting. So for those who are still trying to hang on to the radical hysterectomy, there may be more to come in the next few years as it pertains to that. in that question being explored. Going back to a question from the audience regarding histology. Is there more residual disease in patients that generally have adenocarcinomas versus squamous carcinomas, or did you see more relapses in adenocarcinoma?
No, actually not specifically. No, it didn't come out as a major factor.
Excellent. Very well. So we'll move on to our own Houston Methodist, Gladys Santia.
Thank you. Thank you, Marie, for the opportunity to be here speaking with you, and congratulations to you and your team for all the hard work. My question is, what do you attribute the fact that fewer patients treated with minimally invasive surgery had residual disease in the hysterectomy specimen? And do you think that if this factor had been balanced and minimally invasive surgery had shown a higher rate of residual disease, the results could have been less favorable for minimally invasive surgery, even in this population?
Right. We sort of go around the same sort of issues and questioning. But as I said, I mean, I suspect that surgeons were more likely to choose open surgery in patients who had visible lesion. That's my impression. And so it is possible that if more patients with residual disease had been operated by MIS, maybe we would have seen more recurrences and worse outcome in the MIS group, except what we don't know. So again, it goes back to the inherent weakness or bias of this study is that the surgical approach was not randomized, and it was the surgeon's decision to choose A or B. And as I said earlier, the problem of it is that, and it's good, but we only had 15 recurrences, so it's so much you can tell and make sub-classification and there's so much you can tell with the data. So yeah, that's what we have.
Yeah, and it's I would add also it's a reflection of the already inherent surgeon bias, that it's if you have any reason to consider that a patient may be at a higher risk, then most likely that surgeon is going to choose to go with the open approach. So I think that it's an ongoing question as well. So now University of Wisconsin-Madison, Julia.
Thank you. My question is something that you alluded to in the discussion of the paper. In thinking about increasing the use of minimally invasive hysterectomy for cervical cancer, I was wondering what techniques for minimally invasive colpotomy, specimen removal, and vaginal cuff closure do you think could approximate those used in open surgery to minimize the risk of seeding other spaces? Right.
Well, I think clearly uterine manipulator, particularly with an intrauterine, probe and so on, should not be used when operating a patient with cervical cancer. And I think that if MIS is performed, I personally prefer to close the cervix tight with a suture. And if you want to thread over a cup to sort of delineate the vaginal mucosa, that's quite all right. But to close the cervix tight, and I think that's important. Now, whether you need to define a rim of vaginal mucosa and then take that vaginal mucosa over and cover the cervix in addition, I'm not so sure that that's absolutely necessary, particularly again, in patients who had a pretty deep cone with negative margins where the likelihood of anything left is very small. But I don't know whether you're familiar with the work and publication of Christard. I don't know if I see his name correctly, Christard Kohler, yeah, from Germany. And it's interesting because Christard has proposed, as you probably know, a sort of, I would call it a hybrid procedure whereby he performs sentinel node mapping by laparoscopy, and most of the hysterectomy is performed by laparoscopy or the robot. But then the final part of the hysterectomy, namely the colpotomy and the closure of the vaginal vault, is performed vaginally. So in fact, it is a variant of the Schauter operation, and it certainly to me appears to be a good compromise in the sense that you do most of the procedure by laparoscopy, but you finish it up down below to minimize the risk of contaminating the peritoneal cavity of the vaginal vault. It is a little bit more cumbersome to do, however, but it certainly would be, I think, a good option. So I think that in the end, I think surgeons, should always keep in mind that even in the non-visible in a normal looking cervix, even with a normal MRI, there are still maybe some microscopic tumor cells in there. So you should always operate thinking there might be something, and always be ever so cautious in the technique to avoid contaminating the perineal cavity and the colpotomy. And it's not just the colpotomy, it's the entire surgical technique that we need to be careful about. For instance, when we, mobilize the bladder flap, right? If you're not in the right plane and you sort of go deeper or too deep, you can dig into the cervical stroma, which may not be good if there are some cancer cells in there, which we don't know about. And we also need to be sure to remove the entire donut of cervix, because I've seen some pictures in the SHAPE trial where at the end, the cervix is kind of a cone shape. That means that the edges have been a bit tight. So those are all elements of the procedure to be careful about in terms of the surgical technique. It's not just the colpotomy, I would say. I don't know, Pedro, what you think about that.
Yeah, no, absolutely. And I think it goes back to the element of the patient selection, as you mentioned. I mean, microscopic disease, disease that has been resected already in the cone specimen, squamous carcinoma, then I think that represents a different risk profile than patients who do not meet those criteria. And I would also encourage all of you to look at the article by Chris Tart and the podcast that we did, because I think he goes into very specific details in the context of the LAC trial and in the context of the SHAPE trial. We'll have to ask Masha, how do you actually pronounce correctly Kohler? Our German colleagues. So with that, then let's actually go on to the next question from Valencia. Manel.
Hi, congratulations, Marie, for the paper. I wanted to ask considering that all cervical cancer-related deaths and the majority of extrapelvic recurrence were observed in the minimally invasive group, despite no significant overall difference in outcomes, what underlying factors or mechanisms might account for these results?
Ouch, you guys are tough on me. But that's good. It's good because we have to put everything on the table and not hide anything. And yes, as I said before, there were 2 cases of peritoneal carcinomatosis, and both were in the MIS group. There were none in the open group. Is it just because there were very few open patients? We don't know, but still, it probably is what worries me most in our results. Well, of course, carcinomatosis has also been reported after open surgery, but much less frequently. And other series, I believe, in fact, even in your updated LAC trial, Pedro, I think it was up to 22% as well of carcinomatosis. So others have found the same thing. So it is concerning, and particularly that carcinomatosis is deadly. It's rarely salvageable despite adjuvant treatment. And indeed, the 2 carcinomatosis cases accounted for 2 deaths in our series. So frankly, all efforts should be made or taken to avoid this recurrence. As you pointed out as well, all cervical cancer deaths occurred in the MIS group, and there were none in the open group. Is that coincidence? Is it bad luck? Hard to tell. Again, it's a problem of small numbers. And even though OS, overall survival, was not statistically significant, it is still concerning that all the deaths were in the MIS, right? So when we read articles, that's why we need to be critical. And it's not because there was no statistical significance that it doesn't mean that it doesn't have clinical significance or oncologic significance for our patients. So that keeps me very humble and modest about our results. And, I believe what we have and so on and so forth, but we ought to be better. It should be 0. That's what I would like to. So, right. Yeah. I don't know if
Yeah,
or any
and I
other
think
comments.
I think it also highlights how data is interpreted, because obviously for many surgeons is you interpret it as you see a best fit for your standard practice. And one can say, look, even though this is not statistically different, MIS caused all the deaths. So some would look at that and say, oh, look, statistically there was no difference. So then therefore that's the part that I like. But the fact that, you know, all the deaths were caused, or all the carcinomatosis were caused in the MIS, well, we're kind of overlooked that because it's not significant. So I think it's important to take that in consideration as well.
And if I might add, when we're looking in that other publication, when we're looking at those cases, though they were MIS and they were residual disease on hysterectomy specimen. So it all says the same thing. We're going around in circle. It's always saying the same thing. And when there's visible lesion, I think MIS is probably not the way to go. I don't think, I mean, yeah.
Yeah, and there's another comment from the audience with regards to like, well, we can still see carcinomatosis even after radiation therapy for locally advanced cervix. Mechanism of recurrence may require further evaluation. Yeah, I mean,
Sure,
obviously
sure.
it's a challenge in terms of designing a study for just carcinomatosis, because it's not a common
and
event.
carcinomatosis has been reported after open surgery as well. So it's not just by MIS, but it appears to be more frequent with MIS. So,
Yes.
Right.
Maria, another question from the audience, going back to the histology, they're asking, do you think that histologic subtype may be a factor that helps you triage patients towards MIS versus open surgery when doing a simple hysterectomy? Example, adenocarcinoma with aggressive features according to the Silva classification. Would that change your mind with regards to MIS versus open?
Right. Well, first, just as a precision, but I'm sure everybody knows, but in SHAPE, amongst the low risk criteria, we're always talking about the traditional or standard HPV related histologies. That means squamous, adenosquamous, and adenocarcinoma. So if you have a gastric type or a neuroendocrine or whatever, the other bad histologies is that's not included, right? So then again, in terms of the other characteristics, of course, if you have florid, for instance, LVSI, and if you have a poorly differentiated adenocarcinomas, which is almost 2 centimeters, just do a rad-his, just do it open. I mean, it's just, you know, is nothing wrong with the rad-his. It's not a sin, you know. And I think we should try to look at selecting the very low risk patients, and the others, then let's just, you know, there's nothing wrong with more radical procedure. So yeah, with the adenocarcinoma, the Silva, for instance, C, then that's probably more aggressive than a Silva A, which is probably an AIS. But so it's all of those subtle elements that one needs to analyze when selecting for open or MIS or simple or rad-hist. And that's why it's more than just looking at size of lesions. That's always what I say to our fellows and so on. It is more complicated than that. Yeah.
Excellent. So now we're going to go to Canada, University of Toronto. Stephanie. Wait, Stephanie, we have you on mute. Nope. Let's see.
Can you hear me now?
Yes, perfect.
Oh, sorry about that.
No
Thank you so much, Dr. Plante. I'm the last fellow, so a lot of this you've actually touched on just through the discussion and the great questions from the audience. But my question was that given this is exploratory analysis and hypothesis generating data, until we have further prospective data, do you think clinically, in addition to the low risk SHAPE criteria, that surgeons should consider an open hysterectomy if they did not have a prior LEAP or cone procedure, or when the pathology margins are unknown or positive?
Right. So as you said, that was discussed previously, but I think in a nutshell, we want to repeat that it makes sense, I think, to offer MIS to what I would like now to call most like ultra low risk patients that meet the SHAPE criteria and with pre-op PLEP cone with negative margins and normal MRI. I mean, if you put that all in, my gosh, the probability of a recurrence is very low, regardless of, I think, of how you operate the patient. And as I said, data from CONSERVE and data from GOG 278, data from SHAPE, all say the same thing. The chances of recurrence with negative LEAP cone margins prior to hysterectomy is in the range of 1%. So given that very low rate, it would make sense to offer a simple HIS and maybe MIS, but always remembering the possibility that there might still be residual disease higher up in the cervix. It's been seen in CONSERVE and other trials. So always remain vigilant in the surgical techniques and all the things we've said before. I think the risk of zero does not exist, but I think that if we do a good job by selecting the patients properly, we minimize and reduce that risk, hopefully, to near zero. Yeah.
Excellent.
Yeah.
I was going to mention before we conclude with ESGO meeting coming up in Rome. Certainly, we want to be on Nico's good side, and he certainly promised us a few glasses of wine if we give him an opportunity to speak about the last trial.
Will do.
Really look forward, actually. And we look forward to see you all in 1 month time.
So, Nico, what is the last trial for those who are not familiar?
So the rationale of the last trial was really broadly discussed in this meeting, and I think there is a big rationale after today's meeting. And the last trial is a single-arm trial, which is an interventional trial, as it makes mandatory for all patients meeting SHAPE criteria to have a conization, MRI scan, and then if SHAPE trial are met, the patients undergo minimal invasive simple hysterectomy. The primary endpoint is 3-year disease-free survival. We have a number of secondary endpoints. It's important to highlight that negative margins from invasive disease are recommended at the conization histology. If there are no negative margins, a second conization is recommended, and it is mandatory if MRI scan shows any doubt on residual disease. I learned by Marie, and I have to highlight this as a potential limitation already, that we have a number of false positive and false negative MRI scan after conization. So we need to be careful about this. But after a really broad discussion involving, and I thank Marie and Pedro for really being super active in the discussion and the protocol development as a steering committee, we decided, and I want to also to acknowledge Dennis Kerle, we decided not to make mandatory the second cone, because these are patients with low risk disease, and we don't want them to have 3 operations in a row, meaning 1 conization, 2 conization, and hysterectomy in 3 separate phases. So we decided 1 conization is mandatory with recommended negative margins.
Excellent. Thank you so much,
we
Nico.
would need 1 hour to discuss all the details, but
yes, we will have you. We will have you back for another podcast or journal club. And I also wanted to announce that for those of you who are going to be attending ESGO, Professor Marie Plante is going to be moderating a debate. Myself advocating for open, and Dr. Rene Pareja, who's a very strong advocate of minimally invasive surgery for cervical cancer, will be advocating for minimally invasive surgery. And we love to see you there for that debate. Rene, anything you'd like to add?
Thank you, Pedro and Marie, for putting together this amazing journal club, and we're gonna see you in Europe, and let's see the debate.
I guess following to what you just said, Nicolo, is that, and I've heard that from several colleagues or different sources, that patients are now undergoing 1 and 2 cone, and even more so, sort of slicing the cervix till the end to get the negative margins to then be able to do MIS. I mean, really, as I say, there's nothing wrong with the fan and still incision either, you know. I sort of wonder if we're not sort of going too far out on that line either. I mean, it's something to think about. And we thought we had it all figured out, but now it looks like it's getting more and more complicated, the management of the early stage disease with all those different options now that we have available. Yeah.
Well, I want to thank, first of all, I want to thank everybody who joined. This was a superb journal club. We had at one point approximately 78 to 80 participants. Marie, thank you so much for giving of your time, for accepting our invitation. Once again, obviously for finally presenting to us the SHAPE trial. Everybody was really anxious to hear those results. We're so pleased that it was published in New England Journal of Medicine. And again, of course, obviously that you sent this article to us in the International Journal. I do want to say also thank you for everything that you have done and contributed to do for women with gynecologic cancers. You truly are a remarkable role model for all of us. So thank you for that.
Thank you.
And I also want to thank all the fellows. You did a fantastic job. Your questions were really great, and we thank you for the time and effort that you put into that. Looking forward to seeing everybody in Rome, and I invite you certainly for the Journal Club in February, and we'll see you then for that Journal Club. Happy New Year again to everybody, and welcome to 2025. Thank you so much.
Thank you.
Thank you. Bye.
Bye.